In patients with aortic regurgitation, it is important to note features of congenital disease, connective tissue disorders, inflammatory rheumatologic conditions or systemic infection, evidence of prior cardiac surgery, and signs of heart failure. Examining the hands and arms, focus on stigmata of infective endocarditis, features of connective tissue disorders, and signs of inflammatory rheumatologic conditions. Also note the presence of pulsatile nail beds known as Quincke sign. The classic water hammer pulse can be felt upon raising the arm. The force of the radial pulse increases due to increased cardiac output following the increase in venous return. It collapses because the diastolic pressure is low and the pulse pressure high due to the incompetent aortic valve. Patients with severe aortic regurgitation often have a wide pulse pressure, which is more than 60 millimeters of mercury, due to reduction in diastolic pressure from the incompetent aortic valve. Now focus on the patient's face. Note the presence of head bobbing in time with the pulse, Demusset sign. And in the eyes, note the presence of visible pulsation of the iris, Becker's sign. In the mouth, note quality of dentition, the presence of high arched palate seen in Marfan syndrome, a pulsatile uvula, Mueller's sign, or a bifid uvula seen in Louise-Dietz syndrome. Now look at the neck. Prominent carotid and subclavian artery pulsation may be observed, known as Corrigan's sign. The apex beat in aortic regurgitation is typically volume-loaded and appreciated over a wide area. It may also be displaced and more forceful due to left ventricular hypertrophy. The murmur of aortic regurgitation has the following characteristics: a soft S2 due to failure of leaflet opposition, the presence of an S3 due to volume overloaded left ventricle, a high-pitched decrescendo early diastolic murmur loudest over left sternal border in third intercostal space. An Austin Flint murmur is a mid to late low-pitched diastolic rumble due to distortion and early closure of the anterior mitral valve leaflet. There may also be a mid-systolic component due to turbulent flow across the open valve. The murmur of aortic regurgitation is accentuated by slow expiration. The murmur is also accentuated by maneuvers that increase afterload, such as hand grip. The murmur is diminished by maneuvers that decrease preload, such as Valsalva. Assess the lungs for any pleural effusions or crackles suggesting left heart failure. When summarizing your findings, consider the possible etiologies of aortic regurgitation and the signs of severity.